Hello everyone and welcome to a new session of clinical pharmacology as part of series of central nervous system pharmacology. Today our lecture will be focused on antipsychotic drugs. As you can see here in this slide here we have antipsychotic divided in two generation, first generation and second generation. We're going to differentiate, study the characteristic of each generation. First generation, as you can see here for antipsychotic, the first drug on this list here we have chlorpromazine, then we have haloperidol, the prototype, then we have loxapine, and we have thioridazine, and we have trifluoroperazine. So we have the brand name here on the other side. So we need you to be familiar with this name: chlorpromazine, flofenazine, haloperidol, loxapine, thioridazine. All these medications considered like first generation antipsychotic drugs. Okay, moving to the second generation antipsychotic drugs, number one on the list here, as you can see it, we have aripiprazole, and then we have acinapine, we have clozapine, one of the most important medication on the list, olanzapine, quetiapine, then we have risperidone and ziprasidone. So we have less of medication belong to the second generation. As I mentioned in the beginning, we are going to study the characteristic, the differences between first and second generation, even between the same drug of the group, for example, clozapine, olanzapine, quetiapine, aripiprazole. What is the difference between these medication when you apply it for the patients suffering from psychosis? So as you can see here, as introduction for the antipsychotic, we have a simple definition for schizophrenia. I recommend everyone who is listening to this session, to this lecture, to go back and read the information about clinical medicine, diagnostic testing, and any other related topics to the schizophrenia before we go to the treatment of pharmacology. But in the simple definition for schizophrenia considered like a chronic psychosis characterized by the delusion, hallucination, and disordered thinking. So we have delusion, hallucination, and disordered thinking. This disorder could be genetic or could be due to the biomedical abnormalities. So we have, or could be both. So could be genetic, and this genetic deficiency lead to the biochemical abnormalities. As I mentioned there in the beginning, when you have genetic and this genetic lead to the biomedical abnormalities, this will lead to the dysfunction of the dopamine as a mediator in two pathways. The first pathway will be mesolimbic, and the second pathway will be mesocortical pathways. So what happened there, we have dysfunction in the pathway of mesolimbic and mesocortical dopaminergic neuron. So the main idea, the main pathophysiology, dysfunction in the mesolimbic and the mesocortical dopaminergic pathways. Important issue here in the practice: antipsychotic drugs do not cure or eliminate psychosis, do not cure a thought disorder. Antipsychotic medication reduce the intensity of symptoms such as hallucination and delusions, and improve maybe function for the patient, allow patient to function normally during daily life. Okay, for simplicity here, we are not going to go in depth about schizophrenia, signs, symptom diagnosis. I will leave it for the audience to maybe figure out and read information, because our field here will be focused on clinical pharmacology more than on the pathophysiology or clinical medicine or like diagnostic testing or any other maybe, or differential diagnosis. For example, here the patient suffer from psychosis or schizophrenia may come to the clinic or to the hospital, suffer from positive symptoms or from negative symptoms, as you can see here. So could be positive symptoms, could be negative symptoms. or could be cognitive abnormalities or cognitive symptoms there. So, for example, the patient may suffer from delusion. Okay, the patient may suffer from delusion, hallucination, conceptual disorganization as a positive symptoms, or maybe the patient may suffer from negative symptoms such as allogia, anhedonia, and avolition. Some maybe cognitive symptoms could be appear on the patient, such as impaired attention, impaired working memory, and impaired executive function. In this slide here, we have some definition, and this definition derived from the Merriam-Webster medical dictionary for allogia, for anhedonia, avolition, and we recommend you to go through this definition by yourself when you have time. It's very important to be familiar with this signs, symptoms that a patient with psychosis may suffer from. Understanding the role of dopamine in the central nervous system, consider like the major steps to understand pharmacology, to understand the medication used to treat schizophrenia. So we have two main concepts related to the dopamine on the central nervous system and the brain. The first one, when we have increased level of dopamine, as you can see it here, when you have increased level of dopamine, this is the first one. Increasing level of dopamine in the mesolimbic pathways, where we have the mood and reward functions. So mesolimbic pathway responsible for the mood and reward function. So when you have increased level of dopamine, the patient will come to the clinic or hospital suffer from schizophrenia. Okay, in this case, we need to treat the patient with antipsychotic drugs. The question now, how this medication, antipsychotic drugs, work. As you can see here, the main mechanism of action for the antipsychotic, the main mechanism of action, we have other mechanisms of action. The main mechanism of action of the antipsychotic medication maybe include a block dopamine D2 receptor. So for simple answer for this one, what is the mechanism of action of antipsychotic drug? Antipsychotic drugs blocks dopamine receptor D2 receptor. Okay, the question now, the patient came to the clinic and suffer from the positive symptoms or negative symptom or both for schizophrenia, and you as a physician, healthcare provider, student, prescribe one of these lists on the as antipsychotic to the patient. The patient maybe after maybe 1 week, 2 weeks, 1 month, present to the clinic again with improving symptoms of schizophrenia. However, the patient may suffer from dystonia or akathisia or tardive dyskinesia, and this is related to the something called Parkinsonism. So one of the major side effects related to the dopamine or antipsychotic will be Parkinsonism, or we can call this one extrapyramidal side effect. Another issue here, we try to block the dopamine. The dopamine will decrease in the human body. And we know that from the clinical practice, from the basic and the clinical medicine, we have inverse relationship between dopamine and prolactin. So here our medication, antipsychotic, inhibit dopamine. Inhibiting dopamine, that means decreased level of dopamine in the brain. And the response from the prolactin will be increased secretion of prolactin and cause hyperprolactinemia. So here we need to remember that two things. Number one, extrapyramidal effect or symptoms related to the Parkinsonism, and another one, stimulate pituitary gland, especially the anterior pituitary gland loop, to produce prolactin and cause hyperprolactinemia. Hyperprolactinemia associated with the infertility. So if the patient suffers from hyperprolactinemia, this will lead to the infertility and galactorrhea. Okay, let us discuss maybe the other side of dopamine. The first one, we discuss increased level of dopamine in the mesolimbic and in the pituitary gland. And the mesolimbic lead to the schizophrenia, and the pituitary gland stimulate release of prolactin, cause hyperprolactinemia. Now moving to the situation when we have decreased level of dopamine. If the dopamine decrease in the brain, what happened there? So if the dopamine decrease on the brain, there is situation will be if the dopamine decrease in the brain, the situation will be hyperprolactinemia. Hyperprolactinemia, when the patient come to the clinic suffer from hyperprolactinemia, we can prescribe the anti-dopamine to treat hyperprolactinemia, such as bromocriptine and cabergoline. So we have two medication now. The question now, the situation here, if the patient come to the clinic suffer from hyperprolactinemia and you diagnose the situation by increased secretion of hyperprolactinemia from pituitary gland, the patient has a history of infertility, which of the following medication could be prescribed to the patient to alleviate or improve symptoms? So we have two medication here. We have bromocriptine and cabergoline. Moving to the second part, as you can see here, deficiency or decreased level of dopamine will lead to the will affect the nigrostriatal pathway, or the nigrostriatum pathway, and this responsible for coordination of movement and cause extrapyramidal symptoms, and the patient will start suffering from Parkinsonism. So when you have deficiency of dopamine on the brain and the nigrostriatum corpus, and the situation will be Parkinsonism, like rigidity, tremors. The treatment for this patient, the treatment will be levodopa, siligilene. So when the patients are from one of these medication, levodopa and siligilene, and we cover Parkinson's disease in another lecture, and recommend you to review that lecture. Okay, so what we have here, when the patient come to the clinic suffer from Parkinsonism, or patient come to the clinic suffer from hyperprolactinemia. So both of them will be, we try to prescribe something to activate dopamine receptor. So we try to prescribe medication to activate dopamine receptor. For Parkinson's disease, we prescribe levodopa siligilene, levodopa carbidopa siligilene for Parkinson's disease. This medication increase level of dopamine on the central nervous system, on the nigrostriatal corpus. Moving to the hyperprolactinemia, we can prescribe anti-dopamine such as bromocriptine and cabergoline. So we have the situation here. What happened there? So when you speak about the medication, as you can see here, the medication, when you prescribe medication to enhance dopamine, to increase level of dopamine, so the dopamine level in the brain will be increased with the medication. Two medication here, four medication, levodopa, siligilene, bromocriptine, cabergoline. The result will be increased level of dopamine. Increasing level of dopamine will be associated with the nausea and vomiting, will associated with the hallucination. Okay, the last part here we need to discuss with you what happened there. The patient suffer from schizophrenia, okay, and you prescribe a medication as antipsychotic. Okay, this medication may also affect the CTZ, which called the chemoreceptor trigger zone, and this is zone responsible for nausea and vomiting. So as you can see here, increased level of dopamine cause vomiting and nausea. So increased level of dopamine cause nausea and vomiting. What they found there, so as a side effect, so what they found on the chemoreceptor trigger zone, if the dopamine level increased, so when you have increased level of dopamine in the chemoreceptor trigger zone, this will lead to the activate or cause vomiting and nausea. For this reason here, we try to prescribe dopamine antagonist. So the treatment here for the both for the schizophrenia and for vomiting will be dopamine antagonist. So here we have, when we have increased level of dopamine, the patients are from schizophrenia, nausea, vomiting. How to treat the patient? Prescribe something to block dopamine. Blocking dopamine could be used for treatment of nausea and vomiting, could be used for patients from schizophrenia. The patient as side effect may suffer from Parkinsonism and hyperprolactinemia. Okay. Okay, let us talk pharmacology, clinical pharmacology. We have two category. We have two major group of medication used to treat schizophrenia or psychosis. We have old group. We have new group. We have typical drugs. We have atypical drugs. Okay, the typical old group called first generation antipsychotic, FGAS. Okay, and for the second generation antipsychotic, SGAS. So we have first generation, we have second generation. Okay, we are going to compare between the mechanism of action, effect on symptoms, extrapyramidal, neurological malignant syndrome, endocrine side effect, granulocytosis. So please remember FGA stands for first generation antipsychotic, SGA second generation antipsychotic. The question here, what is the mechanism of action of first generation of antipsychotic? So the answer will be the mechanism of action of first generation mainly block the dopamine receptor D2 receptor. So mechanism of action of first generation will mainly block D2 receptor. That's it. Speaking about the second generation, new generation, atypical antipsychotic. As you can see here, this medication block D2, but it's less. It's less blocking to the D2 receptor and more block to the serotonin receptor, especially 2A. We have other medicine or other medication block 1A also. So remember, a typical less blocking to the D2 receptor, but it's more blocking to the serotonin receptor 2A. Okay, first generation mainly affect positive symptoms, and the second generation mainly affect the negative symptoms. Extrapyramidal is like more common in the first generation, less common in the new generation. Malignant hyperthermia more common in the first generation, less common in the new generation. Endocrine side effects such as obesity or increasing weight, diabetes, more common in the new generation, the second generation, and less common with the first generation. A granulocytosis, which means decreased number of white blood cells and polymorphonuclear sites. So it's common here. I will type, maybe you can type 4, you can type here 1. So this slide here is, I believe, is very important to compare between first and second generation. Which of these medication mainly block dopamine receptor? We have first generation. Which of these medication block dopamine receptor and serotonin? We go the second generation. Which of these medication mainly affect the positive symptom? First generation. Negative symptom? Second generation. Which of these medication associated with the extrapyramidal effect or neuromalignant, neuroleptic malignant syndrome? We have it like first generation. Endocrine and granulocytosis as second generation, and we can call this one a typical antipsychotic. This slide here summarizes what we have in the table before. This is the table here. I will go back to the table. To show you. This is the table, comparison table, and this is repeat information. First generation, older generation, called typical. So we have first generation, older generation, or called typical antipsychotic, mainly block dopamine D2 receptor and treat positive symptom of schizophrenia. The newer medication called second generation or typical, or a typical antipsychotic, less affinity towards D2 receptor, high affinity towards 5H2 receptor, and treat both positive and negative symptom of schizophrenia. In this slide, they defined the typical, the old generation of antipsychotic in two group. We have two group. We have high potency, we have low potency. High potency, you can see high potency, a typical antipsychotic. That means this medication has high affinity, greater affinity towards dopamine receptor. That at lower dose may produce the effect. And example for the high potency antipsychotic, we have haloperidol, flofenazine, and you can go the rest. Okay, this medication with a high potency need less dose, greater affinity to the dopamine, but it carry the risk of higher extrapyramidal effect, EBS. and neurologic malignant syndrome. Okay, so for the high potency haloperidol flofenazine, higher incidence of extrapyramidal neuroleptic malignant syndrome, but this group of medication has lower incidence of anticholinergic, antihistaminic, or anti-ham. Okay, moving to the second group of typical. For the typical, we have low potency typical. This medication, from the name low potency, that means this group of medication have a lower affinity to dopamine receptor. Because it has lower affinity, we need higher doses to produce the effect. Here with the first group, we need only low doses because this one considered like high potency. Chlorpromazine, thioridazine. So for the low potency, chlorpromazine and thioridazine. This group of medication has maybe have a lower incidence of extrapyramidal and malignant thermia, neuroleptic malignant syndrome, sorry. So lower incidence of extrapyramidal and neuroleptic malignant syndrome. If you compare that with what happened with the cholinergic or anti-ham, what happened there? They found their low potency antipsychotic have a higher incidence of anticholinergic, antihistamine comparing with the high potency. So this medication considered like more anti-ham. So ham stands for histamine, alpha, and muscarinic antagonist. Anti-ham, I will type it again. H for histamine, A for alpha adrenergic, M for muscarine. When we say anti, that means black histamine, black alpha, and black muscarinic. So the second maybe the typical antipsychotic low potency has more effect on the histamine, alpha, and muscarinic receptor. Okay, we need to look on some maybe brief and pharmacokinetic for both. We still speaking about the typical, and atypical antipsychotic. We have oral forms. Given orally, and we have injectable form, parenteral form. For oral form, well absorbed and lipid soluble, readily arrive or enter the central nervous system. It's very important to arrive to the central nervous system. Many of these medications bound extensively to the plasma protein, and this could mean important topic for us. For example, if the patient come to the emergency room and this patient, for example, take 25 tablet of clozapine. Okay, so 25 tablet of clozapine and intentionally to commit a suicide. The situation here, this group of medication will arrive to the blood, and mainly in the blood will bind to the protein. As you can see here, highly bind to the protein. So when you try to do the hemodialysis, the drug will be remain on the blood because the drug is binding to the protein. They does not allow the drug to leave the protein. Okay, long plasma half-life. This medication, most of these medications consider like once daily dosing because they have long half-life. Moving to the injectable form or parenteral form, we have several medication: flofenazine, haloperidol, olanzapine, risperidone, alipiprazole. This medication is available for rapid initial therapy when you need, like when you have injection. Sometimes we can prescribe to the patient in an operative patient, for example, or when you have depot treatment here as long treatment, to like twice per year or like 3 times per year. And part 1, we discussed the definition of antipsychotic. Then we went through the list of medication belong to the first and second generation antipsychotic. Then we have some definition for schizophrenia, etiology, genetic, and biochemical abnormality. We discussed that with you. Then we brought to the light the the clinical presentation include the positive symptoms, negative symptoms, and cognitive symptoms. We have some definition. We went through that definition, and then we discussed the most important topic before we go to the second part. We discussed the role of dopamine in the central nervous system. We have two cases associated with the increased level of dopamine on the brain. So when you have increased level of dopamine in the mesolimbic, the patient might suffer from schizophrenia. For this reason, we use antipsychotic. When the patient suffer from increased dopamine level in the chemoreceptor trigger zone (CTZ), the patient might suffer from nausea and vomiting. Therefore, we can use metoclopramide and domperidone to treat this patient. Patient treated with the antipsychotic or with the anti-vomiting, such as metoclopramide and domperidone. These two type of medication block the dopamine receptor, and as a side effect or adverse drug reaction, the patient here may suffer from Parkinsonism and hyperprolactinemia. So this is one example for increasing level of dopamine. Another example for decreasing level of dopamine. Decreasing level of dopamine may affect the nigrostriatal pathway, and if this level decrease in this anatomical site, the patient may suffer from Parkinsonism. And two medication, popular medication, levodopa, carbidopa, could be used to treat Parkinson. Siligilene could be used to treat Parkinson. And these medication work on the dopamine receptor by activating the dopamine receptor. If the dopamine receptor decrease in the pituitary gland, the result will be hyperprolactinemia. And how to treat patients with hyperprolactinemia? We have two medication, bromocriptine and cabergoline. Bromocriptine, cabergoline considered like medication used to activate dopamine. Okay, so two things: deficiency or increase. Increased level of dopamine could lead to the schizophrenia, vomiting. Decreased level of Parkinsonism, but decreased level of dopamine could lead to the Parkinson and hyperprolactinemia. So here we talk about the anterior pituitary lobe. Anterior pituitary lobe responsible for secretion of prolactin. Okay, so the situation here, we have hyperprolactinemia. The patient may suffer from adenoma or tumor in the pituitary. Therefore, the medication used for hyperprolactinemia only to treat symptoms and signs for the patient. It's not treating the cause of the disease. We have to maybe prepare a specific diagnosis, identify the cause, and treat the cause. For example, if you have adenoma, maybe we need a surgery for this adenoma, or like chemotherapy for the adenoma. Depends on the situation, could be malignant, could be benign. So we have different approach according to the situation. Then we discuss the differences between the first generation antipsychotic drugs and second generation antipsychotic drugs. We have list of medication there, and we went through the first group of medication, the first group of medication, or like all the group of medication, we have high potency and low potency. We discussed that with you. Then we went through the what type of pharmaceutical form we have in the practice. We have oral form, we have injectable form. We discussed it also. Now we start with the new chart for the how this medication work. When you prescribe your medication like antipsychotic, how the antipsychotic work. Speaking about the mechanism of action of antipsychotic, antipsychotic treatment built on the hypothesis that said the patient suffer from schizophrenia may suffer from the relatively excess of activity of neurotransmitter responsible for releasing dopamine. So we have increased level of secretion of dopamine, not only in the mesocortical here. It's not only in the mesocortical. This one should be involved mesolimbic. So we have mesolimbic and mesocortical. The situation here, we have mesolimbic and mesocortical, and this will lead to the positive symptoms and the negative symptoms here. So the main idea for the treatment, we have dopamine hypothesis and schizophrenia, which maybe expected to see relatively high level of activity of dopamine. So our medication will target the dopamine axis, will inhibit dopamine axis in the mesolimbic and mesocortical pathway. So as you can see it here, the dopamine hypothesis in schizophrenia suggests that a disorder results from excess of dopamine activity on the specific mesolimbic pathway on the brain. So the main pathophysiological, the main target for us for treatment, for pharmacological approach, will be the high level of dopamine activity on the mesolimbic pathway. Okay, this image here, this figure present. Let me stop this one. Okay, this image here or picture present the dopaminergic neurons. Two parts. You can see here we have presynaptic neurons, then we have postsynaptic neurons, as you can see it here. On the in the presynaptic neuron, we have the dopamine enter the fiscals through the tyrosine convert to the dopa convert to the dopamine, and the dopamine enter the fiscals. For more detail about this tyrosine, dopamine, I refer you to the anti-Parkinson disease. We have the neuron there with a lot of details regarding the synthesis and release of dopamine. But for simplicity in the slide, we show you only the dopamine enter the fiscals, and then the dopamine release and the synaptic cleft, then the dopamine binding to the receptor. You can see the receptor, the tiny component here. The dopamine bind to the receptor. This receptor, we have a specific type of receptor here. We have D2 receptor. Then we have D2 receptor available in the postsynaptic neuron and the presynaptic neuron. So the dopamine D2 receptor available in two main places, postsynaptic and presynaptic. Again, we have another component here. We have another important component. We have dopamine reuptake. So in the next slide, we'll show you the target for medication for the antipsychotic drugs. Again, I would like to repeat it before we move to the next concept. The dopamine enter the fiscals. The fiscals arrive to the synaptic edge or synaptic cleft and release the content of dopamine, and the dopamine bind to the receptor. What we have here, we have D2 receptor. D2 receptor will be activated and responsible for to stimulate the mesolimbic, stimulate the pituitary gland, lead to the schizophrenia or vomiting. Okay. This is the important diagram here. You can see that dopamine receptor, when the dopamine receptor empty, there is no action. So when your dopamine receptor empty, the result will be no action. So what we have here, as you can see, the receptor is empty when the dopamine D2 receptor, is empty. You can see it here. When the dopamine receptor is empty, there is no action. This is on the level of physiology. Then we have the dopamine particles. We have dopamine particles. This is the dopamine particles here. The dopamine particles bind to the receptor and activate the receptor. So you can see it here, activate the receptor, and this will lead to the physiological function. So physiological functions, you can see it here. This physiological function responsible for the movement, memory, pleasurable reward, and motivation. So we need dopamine for our normal physiological life. Dopamine is very important things because deficiency of dopamine may cause Parkinson disease, for example. Okay, moving to the next slide. This is what we have. This is a disease we have in there. So what they found there, overproduction of dopamine. You can see here we have more particles. I will go back to the previous slide. You can see the dopamine here bind to the receptor, produce physiological action. If you move to the next slide, you can see the dopamine here binding to the receptor. What happened there? Binding to the receptor, but we have a lot of dopamine there in the central nervous system, and the result will be overactivation of dopamine receptor in the mesolimbic mesolimbic pathway. And this mesolimbic pathway, D2 receptor, responsible for mood and reward. When you have overactivation of this area, the result will be schizophrenic symptoms. The patient may suffer from positive or negative symptoms. The patient may suffer from delusions or hallucination or a negative symptom, anhedonia or evolution. So we have a negative positive symptom related to the overactivity of dopamine in the central nervous system. Okay, so when you prescribe antipsychotic to your patient, antipsychotic, as you can see here, the antipsychotic, this green rectangle, bind to the dopamine receptor, D2 receptor. So the antipsychotic bind to the D2 receptor, okay, and block the receptor. And we can call this one prevent dopamine from binding to the receptor. This is number one. So number one, antipsychotic bind to the receptor and prevent the internal dopamine from binding to the receptor. Number one. Number two, sometimes we have dopamine binding to the receptor. So our medications here, the next maybe another option for the medication to work as an antipsychotic. You can see it here in the graph. The antipsychotic displace the dopamine from the receptor, remove dopamine from the receptor, and occupy the receptor. So we have two options. Number one, binding to the receptor, prevent dopamine from binding to the receptor. Number two, the antipsychotic arrive to the receptor, displace the dopamine, and occupy the receptor instead of dopamine. Okay, so now again, this is our medication here in this diagram. We are familiar with diagram now. When you prescribe dopamine to the patient, you can see it here. The dopamine arrived to the synaptic cleft, and the dopamine occupied the receptor. You can see here the dopamine occupied the receptor, pre and post location, and prevent dopamine from binding to the receptor, and the result will be decreased activity of dopamine. So the main idea from using antipsychotic to block dopamine, to decrease dopamine activity in the central nervous system. Okay, again, this slide here tried to explain what happened, what type of medication we are going to use. This slide here show that we have two types. This slide here show two types of antipsychotic. We have typical antipsychotic. We call this one first generation antipsychotic. And we have atypical antipsychotic. We can another name for antipsychotic neuroleptics. So we have antipsychotic or a neuroleptic. So we have typical antipsychotic or atypical neuroleptic. This one represents the first generation of antipsychotic. Medication belong to this group. We have chlorpromazine, thioridazine, flofenazine, haloperidol. How this medication work? This medication antagonize the D2 receptor with a high potency. This medication mainly affect the D2 receptor in the brain and in the mesolimbic. And this medication better maybe to consider like the best treatment for the positive symptoms. This medication may associated with the extrapyramidal side effect. So this is what we have regarding first generation typical neuroleptic or antipsychotic. First generation, I will repeat that. Okay, clean the whiteboard here for you. So what we have here, first generation, okay, first generation antipsychotic, we call the first generation typical neuroleptic, FGAs, first generation antipsychotic. Example of this medication, chlorpromazine, thioridazine, haloperidol, flofenazine. How this medication work? By blocking, antagonize D2 receptor. And this medication present high potency towards the D2 receptor. This medication considered like the best treatment for the positive symptoms more than negative symptoms. This medication, first generation, may cause extrapyramidal effect as a side effect. Moving to the second generation, of S stands for second generation for antipsychotic, and another name atypical neuroleptic. So we have typical, then we have atypical. For atypical, maybe the one the prototype, the main medication in this group, aripiprazole, followed by risperidone, quetiapine, clozapine, and ziprasidone. So we have list of medication. This medication block dopamine receptor, but with a low potency. So if you compare this one with the first generation block dopamine with a high potency. Second generation, a typical neuroleptic, a block dopamine D2 receptor with a low potency. But in addition to the D2 receptor, this group of medication also antagonize or blocking the serotonin receptor. Here we are talking about 5-HT2A, and one of them could be 1A. Okay. This medication maybe covered mostly the negative symptoms more than positive, but could be covered both, but mainly focus on the negative symptoms. This group of medication, a typical second generation, considered like as a side effect, may cause anticholinergic and metabolic effect. That a typical neuroleptic second generation, this is the first line for schizophrenia because it's like less side effect. So if you go back to the previous slide, you can see there a typical antipsychotic, a typical neuroleptic, considered like the first line treatment for psychosis or schizophrenia. The reason, because we have selectivity there. With the second generation atypical, we have selectivity in mainly work on the D2 receptor and 5-HT2A receptor. We have type of selectivity with the second generation. So a typical antipsychotic considered like drug of choice, first line therapy. What about typical antipsychotic, first generation? We call that a typical, we call that typical antipsychotic, psychotic, considered like first generation. Why we don't prefer this group of medication? We have the reason here. As you can see here, this group of medication, first generation antipsychotic, it's not specific medication, not selective medication. If you look on the first generation, a typical antipsychotic, we don't recommend to use it. Very popular in practice, but it's available there. We can use it sometime. The first line treatment, atypical. The first line treatment, aripiprazole, for example. But what about typical? As you can see here from this this image here, or this diagram, this first line generation of antipsychotic block dopamine D2. This is number one. This group of medication block alpha 1, alpha adrenergic receptor. This medication block histamine 1 receptor. This medication block M1 muscarinic receptor. So maybe someone can tell me that this group of medication considered like non-selective. This group of medication block dopamine receptor, alpha adrenergic receptor, histamine receptor, and muscarinic receptor. Therefore, the patient will suffer from side effect. I believe you agree with that, because this medication considered like non-selective, not only blocking dopamine, blocking alpha adrenergic, blocking histamine receptor and muscarinic receptor. So several type of receptor will be affected by the typical antipsychotic. We expect patient to suffer from adverse drug reaction or unwanted effect. Okay, we are still talking about typical antipsychotic or first generation antipsychotic. Okay, we still, and first generation antipsychotic, we still talking about this group of medication. As you can see here, we classify them to the three main group. As you can see here, we have three main group from typical or first generation. We have high potency, low potency, and medium potency. So for high potency, represented by the haloperidol, and we have another flofenazine, for example, other medication. We go the bold one to remember that. So high potency, example for the high potency, haloperidol. This haloperidol with the high potency carry the risk of a high risk of extrapyramidal symptoms. So high risk of extrapyramidal symptoms. Low risk of the HAM effect. HAM effect stands for histamine, alpha adrenergic, and muscarinic effect. Low risk. So for high potency, first generation carry the high risk of extrapyramidal symptoms, but at the same time has low risk of HAM effect, which means histamine, alpha adrenergic blocker, and muscarinic blocker. The patient in this case suffer from less side effect as hypotension, tachycardia, or cholinergic effect. So we're done with the hypotension. So hypotension mean it's like effective medication, but there's extrapyramidal effect and lower ham, lower anti-ham, and ham stand for histamine, alpha, and muscarinic. What about low potency? Low potency, the drug name for the low potency, chlorpromazine, and we have theoridazine. So low potency, the main drugs in this group, the bold one, the chlorpromazine. You can see this group of medication has low risk of extrapyramidal, but it has a high risk of anti-ham. Anti-ham mean antihistamine, or alpha blocker or muscarinic blocker. Medium, we have medium potency, we have loxapine as prototype. They have medium extrapyramidal and medium anti-ham or anti-ham. Okay, so you can see here we have first column here. The first column represents the category of first generation antipsychotic according to the potency. We have high potency, medium potency, and low potency. We have another category for the first generation typical antipsychotic according to the chemical structure of this medication. We have phenothiazine, we have dibenzifene, we have butorphanone, and we have thioxanthine and indolence. So for example, if you ask about chlorpromazine, belong to the phenothiazine. Okay, what about the haloperidol? Haloperidol belong to the butorphanone groups. So this is the situation. For example, bimozide, very important medication. We are going to discuss that later on for the Tourette syndrome, for example. Okay, this image here or this slide present the action of antipsychotic, a typical antipsychotic. Okay, this medication present a typical antipsychotic, atypical, which means second generation. We are speaking about second generation antipsychotic, and this group of medication block the dopamine receptor and block 5-HT2A receptor. So we have, it could be like more selective medication, blocking dopamine receptor D2 and block histamine receptor 2A. Okay, so we discussed the target for the which type of receptor will be affected by the second generation with that, or we call it a typical antipsychotic. Example with the brand name, generic name. We have the brand name, we have the generic name, we have aripiprazole, acinabine, clozapine, then we have olanzapine, quetiapine, risperidone, and ziprasidone. So we have list of medication here for the treatment belong to the second generation. We have here the clozapine or clozapine. Clozapine appears to be offer greater effectiveness for patients suffer from resistance schizophrenia. So you place the patient on the treatment, the patient that does not respond to the treatment, this is the alternative. The clozapine not first line treatment for the patients suffer from schizophrenia. The clozapine could be the last line resort for the patient because the risperidone will be keep it for the patients suffer from non-response to the traditional treatment of schizophrenia. Okay, for mechanism of action, here we have it in the text, but we already discussed it in the graph before in the chart. As you can see here, they mentioned there all first generation antipsychotic and most second generation block dopamine receptor. We have different affinity. Most second generation block serotonin receptor, especially TA receptor. Or 2A receptor. So first generation block and most of second generation block dopamine receptor. Second generation, in addition to the blocking dopamine receptor, block serotonin receptor 2A. Then they try to remind us with a group of medication belong to the second generation: olanzapine, quetiapine, acinabine, risperidone. This group of medication maybe have high affinity towards the serotonin receptor 2A. So also they interact with the D2 receptor and other receptor. Clozapine, according to the recent information for clozapine mainly block D4 receptor. Clozapine block the 5-HT2 receptor, and has virtually no affinity for D2 receptor. Clozapine used for resistance schizophrenia. Please remember that. So we can discuss that D4, serotonin 2, and use it for the resistance schizophrenia. And we have the reason here. Clozapine carry the risk of severe side effect. We don't recommend to use it. Okay. Okay, the next medication on the list here we have bimefanserin. Bimefanserin has no affinity towards dopamine receptor, and bimefanserin approved by the FDA 2016 to treat patients with the Parkinson's disease psychosis. And this is an only, we don't use it for schizophrenia. Bimefanserin belong to the antipsychotic, but this medication used for Parkinson's disease psychosis. Okay, I'm sharing the screen about the information leaflet about bimefanserin. You can see it here for bimefanserin. This medication used for this medication belongs to the atypical antipsychotic and used for patients suffer from Parkinson's disease associated with the psychosis, not for regular psychosis. So when you have patients suffer from Parkinson's disease associated with that psychosis, this is a medication. This is a drug of choice. So we have it here. It's approved by 2016. Nebulized bimefanserin tablet for oral use, and it's like we have used it for patients of Parkinson's disease associated with the psychosis. So please remember, bimefanserin has no affinity towards dopamine receptor. FDA approved for Parkinson's disease with the psychosis. Okay, this list here you can see we have ziprasidone, aripiprazole, acinabine, lorazepam. What is the common things between all these three medication? You can see here all three medication affect the serotonin receptor 2A, affect 2A, 1A, serotonin receptor. The second medication also affect 2A, 1A. The same apply here, 1A, 2A, in addition to the dopamine receptor. And so you can see here all these three medication, ziprasidone, aripiprazole, acinabine, lorazepam. Okay, regarding the clinical use of antipsychotic, we use it to treat patients suffer from schizophrenia. We use it to treat patients suffer from schizophrenia. We use it for treatment and prevention of nausea and vomiting. We have chlorpromazine used to prevent nausea and vomiting induced by the chemotherapy. How this medication work, antipsychotic, by blocking the D2 receptor and the chemoreceptor trigger zone CTZ. So the medication for nausea and vomiting prevention, number one, again, this big group of medication, antipsychotic, the main use is like schizophrenia. So this medication, the only drugs approved for schizophrenia, reduce hallucination and delusions, and this one considered like positive symptoms of schizophrenia. This medication also treat the negative symptom of schizophrenia, especially when you talk about second generation. So the first generation cover positive symptom, second generation cover both positive and negative. So second generation cover both negative and maybe negative and positive symptoms of schizophrenia. This will talk about second generation of antipsychotic. Long acting, we have long acting here. Injectable could be once per week or once per every month, for example. The patient could be placed on 2 or more medications, and the therapy could be last for years. Okay, before we move to the other uses, I would like to emphasize the clinical use, many clinical use for the psychotic, many clinical use, as you can see it here. Okay, so number one will be schizophrenia. Number two, prevention and treatment of nausea and vomiting. Number three, we have other uses. For example, we need to keep it in our mind. We can use it as a tranquilizer for patients from agitation. We have risperidone and aripiprazole. This medication used for disruptive behavior, irritability associated with the autism. Okay, so for autism here, if you click on the link here, and we look on the FDA approved from Bristol Myers Squibb, you can see here U.S. Food Drug Administration approved Abilify aripiprazole for the treatment of irritability associated with the autistic disorder in pediatric patient aged 6 to 17 years. So we use aripiprazole for autism, for behavior, for disruptive behavior. We use it for disruptive behavior associated with the autism. So aripiprazole could be used for autism. So the question here, which of the following new generation of antipsychotic medication could be used for the treatment of disruptive behavior and irritability associated with the autism? The answer will be risperidone and aripiprazole. Moving to the next one, chlorpromazine. Chlorpromazine could be used for intractable hiccup. Intractable hiccup mean the hiccup not response to traditional treatment. We can use chlorpromazine for the treatment. Last medication on the list here, bimozide. Bimozide, this is primarily indicated for treatment of tics, and this associated with the Tourette syndromes or Tourette disorders, such as a case associated with the inherited genes deficiency. We have maybe some pictures or videos available for Tourette syndromes. I will share it with you later on. The last one here, loracidone, quetiapine, used for bipolar disorders. So loracidone, quetiapine for the bipolar disorders. So from this slide here, I will repeat the first one of the previous slide. The antipsychotic used for schizophrenia. Number 2, nausea and vomiting. Number 3, agitation. Number 4, autism. Number 5, hiccup. And bimozide, Tourette syndrome, bipolar disorder, bipolar depression, loracidone, quetiapine. So you can see it here. This medication, we have several clinical applications, several clinical use, not only antipsychosis or antipsychotic medication, not only schizophrenia. Schizophrenia, nausea, vomiting, agitation, autism, hiccup, Tourette syndrome, bipolar disorder. So the question we can ask ourselves about, we use the antipsychotic first generation, second generation for the treatment of psychosis, nausea, vomiting, autism, hiccup, and bipolar disorder. What about side effect? Is there any side effect associated with the antipsychotic? So this slide here represents the adverse drug reaction associated with a typical antipsychotic. They said this medication, this group of medication considered associated with the anti-dopaminergic side effect. Anti or anti-HAM effect. We call that HAM stand for histamine, alpha, and muscarinic. And this medication mean anti or anti mean they block histamine, block alpha, block the muscarinic. The patient may suffer from tardive dyskinesia. The patient may suffer from dystonia or akathisia or bradykinesia. So all these like neuroleptic malignant hyperthermia. So all these like consider like the side effect or like important serious side effect when you talk about malignant neuroleptic malignant syndrome. This is an emergency case. Or like when you talk about tardive dyskinesia, this is a chronic administration effect. So some of the textbook and study are published article, they said when the patients suffer from tardive dyskinesia, this is considered very serious side effect due to the antipsychotic medication and may lead to the permanent disfiguration of the face. Okay, so we have the link here and you can watch the YouTube regarding the permanent disfiguration of the face. Okay, this is from the YouTube to show you the tardive dyskinesia. Okay, so you can see it here, and another one. Okay, so both of them belong to the tardive dyskinesia, as you can see here. So that tardive dyskinesia could be a serious side effect of antipsychotic, lead to the permanent disfiguration of the face. So we have two links here from the YouTube. I recommend you to watch it at your own time. Okay, continue talking about the side effect when you prescribe the antipsychotic, especially the first generation. The patient may suffer from extrapyramidal side effects such as dystonia, akathisia, Parkinsonism, hyperprolactinemia, and the neuroleptic malignant hyperthermia. The patient also may, this is the antidopaminergic. So the main idea here, extrapyramidal effect, prolactin, and neuroleptic malignant syndrome. Moving to the anti-ham or anti-ham side effect, we have antihistamine, we have anti-alpha adrenergic, which means alpha blockers, then we have anti-muscarinic. So here we expect maybe the audience to be familiar with the effect of antihistamine. The patient may suffer from sedation. Moving to the alpha blockers, when you block alpha receptor, the patient may suffer from orthostatic hypotension, cardiac abnormality, sexual dysfunction. Speaking about the anti-muscarinic effect, so here we type here atropine effect, atropine-like effect. So the patient suffer from anti-muscarinic effect, dry mouth, tachycardia, urinary retention, blurred vision, constipation. So you can see all these side effects. So two main side effects. Number one, antidopaminergic, extrapyramidal, hyperprolactinemia, neuroleptic neuroleptic malignant syndrome. I will clean the whiteboard again. So we have the two main side effects related to the dopamine effect. Antidopaminergic effect could be extrapyramidal side effect, dystonia, akathisia, Parkinsonism, hyperprolactinemia, neuroleptic malignant syndrome. This is the antidopaminergic adverse effect related to the antipsychotic drugs. Anti-ham side effect, ham stands for histamine, alpha muscarinic. So our medication antipsychotic, especially first generation, block histamine, block alpha, block muscarinic, so carry the risk of antihistamine. The patient may suffer from nausea, suffer from antihistamine, suffer from sedation, hypnosis, blocking alpha receptor, the orthostatic hypotension, cardiac abnormality, sexual dysfunction. Muscarinic effect, the patient come to the clinic, suffer from dry mouth, tachycardia, urinary retention, blurred vision, constipation. Weight gain, big issue. Weight gain, the patient coming with a weight gain, elevated liver enzyme, ophthalmologic problems here. We have some medication may cause corneal deposits, chlorpromazine, and other medication, thyroidazine, associated with the retinal deposits here. So if you Google it or look on the images there, they give you more information about this two medication. So the question here, which of the following antipsychotic medication cause corneal deposits? Chlorpromazine. Which of these medication cause retinal deposit? We have thyroidazine. Okay, the slide here, the purpose of this slide here to explain the two main topics related to the ADR. Number one, we are going to explain the extrapyramidal effect. Number two, to explain the neuroleptic malignant syndrome, NMS. So regarding the extrapyramidal effect, a normal person, we have balance in the striatum between the dopaminergic neurons. We have balance between dopaminergic neuron and cholinergic neurons. So this is in the normal person, in normal healthy subject, we have balance between between two neurons, between dopamine neurons and cholinergic neurons. Okay, so what we have here, we have balance between dopaminergic neuron and cholinergic neuron. When you prescribe anti-dopamine, when you block the dopamine, the result will be increased level of acetylcholine. So we have increased level of acetylcholine here. So the situation here, when we prescribe, when you block the dopamine receptor, this causes excess of cholinergic activity. So when you block dopamine receptor, this will increase activity of cholinergic neurons, and the patient may suffer from extrapyramidal effect due to the blocking D2 receptor. The patient may suffer from dystonia, akathisia, Parkinson-like symptoms, tardive dyskinesia. I'm not going to discuss that time, 2 hours, days to weeks, days to weeks. And you can see here tardive dyskinesia is the occur after months or year of treatment, and especially with the first generation antipsychotic. So tardive dyskinesia is like a chronic side effects, not like early side effect. So please remember that the patient may come to the clinic from dystonia in the beginning. This will develop to the akathisia, Parkinson-like symptoms, and after chronic treatment, months or years of treatment, the patient may suffer from tardive dyskinesia, which is considered like irreversible. Now the question, how to treat patient with the tardive dyskinesia due to the treatment with the antipsychotic. Number one, we need to, first of all, patient here come in like Parkinson's disease. So tardive dyskinesia, patient present Parkinson's disease symptoms, but they said don't prescribe levodopa. So the patient here, okay, you place the patient on the first generation antipsychotic. The patient come to the clinic suffer from tardive dyskinesia. So here we have decreased dopamine, and decreasing dopamine causes tardive dyskinesia. The situation here, they said don't prescribe this. Tardive dyskinesia is like one of the symptoms of Parkinson's disease, Parkinson-like syndrome here. We know that the first medication for Parkinson's disease levodopa, but the situation here for tardive dyskinesia, they said don't give levodopa because levodopa may cause psychosis here. Levodopa increase dopamine, and this patient suffer from schizophrenia. We don't recommend to use levodopa to this patient. So number one, don't prescribe levodopa. Number two, the patient here suffer from excess cholinergic activity. What happened? Can we prescribe atropine? Yes, but we don't have atropine for this one. We have something much better called benzotropine. So the first choice for the tardive dyskinesia will be benzotropine, and then they recommend to decrease the dose of first generation medication, or we recommend to switch the patient to the second generation of antipsychotic. So we have approach for tardive dyskinesia. If tardive dyskinesia happened, if extrapyramidal happened, the situation, number one, don't give levodopa. Number two, prescribe antimuscarinic such as benzotropine. Number three, decrease doses of first generation, or switch the patient to the new second generation antipsychotic, or like a typical antipsychotic. Okay, speaking about the second major side effect for the antipsychotic, we are talking here about speaking about the neuroleptic malignant syndrome, NMS, neuroleptic malignant syndrome here. Okay, the second most important side effect, neuroleptic malignant syndrome, as you can see it here, more common with the high potency first generation, can happen any times. This side effect could consider like life-threatening emergency, psychiatric emergency, require treatment. The patient come to the hospital, suffer from muscle rigidity, myeloglobinuria, rhabdomyolysis, fever, and this could lead to the acute renal failure. A treatment for the neuroleptic malignant syndrome, we have 3Ds. For the neuroleptic malignant syndrome, 3Ds. First D stands for discontinuation of antipsychotic drugs. And the second D stands for dantrolene. Dantrolene used as a muscle relaxant. The third D, use dopamine agonist, use bromocriptine. So we have 3Ds for the neuroleptic malignant syndrome. Number one, discontinuation of treatment. Number two, dantrolene. Number three, dopamine agonist, was represented by bromocriptine. Okay, this table here represents the medication or drugs used for patients suffer from extrapyramidal symptoms. As you can see here, the highlight represents the group of medication. We can prescribe antimuscarinic, such as benzotropine. This is drug of choice. We can prescribe diphenhydramine. We can prescribe beta blockers for the extrapyramidal effect, benzodiazepine to maybe to induce to lessen the anxiety and reduce the convulsions for the patient, and extrapyramidal involuntary muscle contraction. So we have list of medication, benzotropine, one of these medication on the list here, benzotropine, diphenhydramine, amantadine, lorazepam, diazepam, propranolol. All these group of medication could be used. Antimuscarinic, antihistamine, dopamine agonist, benzotropine, and beta blocker. This is a list of medication, a group of medication could be used for treatment of extrapyramidal effect. Moving to the very important medication belong to the atypical antipsychotic. Clozapine. Clozapine belong to the atypical. Number one, the clozapine belong to the second generation antipsychotic. Clozapine, as you can see here in the screen, considered like very strong drug, but it has lot of adverse drug reaction and black box warning. What we mean with the black box warning, this is coming at the top of the prescription leaflet information. Black box warning, we are going to present it for you. Click on the link here and read the information. Clozapine appear to offer greater effectiveness in the treatment of resistance schizophrenia. So again, remember that clozapine is not the first medication for patients with schizophrenia. This is the last attempt, last option for patients suffer from schizophrenia who does not respond to the classic or conventional treatment of schizophrenia. This medication have efficacy against the negative and positive symptoms, less likely to cause extrapyramidal symptoms. Regarding the black box warning for the clozapine, also only mention the major bullet here, major points. Number one, the clozapine inhibit bone marrow toxicity. The patient suffer from severe neutropenia here, and this is associated with the granulocytosis, which means decreased number of white blood cells, and especially talking about polymorphonuclear granulocytosis, white blood cells will be decreased, and there is a risk of life-threatening infections if the patient got infected with the bacterial, and there is a risk of life-threatening infections due to the maybe decreased number of granulocytes. The patient may suffer from orthostatic hypotension, bradycardia, seizure with the clozapine. Clozapine may cause myocarditis, cardiomyopathy. Clozapine, when you prescribe it to the elderly, they found the clozapine increased risk of mortality in the elderly patient with dementia-related psychosis. So when you have elderly patient like 75, 80, they suffer from dementia and psychosis. If you prescribe this medication to the elderly people with dementia and psychosis, they found that clozapine increased mortality in the elderly patient with the dementia and psychosis. So again, for clozapine, black box warning, bone marrow toxicity associated with the neutropenia, granulocytosis, myocarditis, cardiomyopathy, mortality, increased mortality in elderly patients suffer from dementia and psychosis. Let us click on the link here and read some information about clozapine. Okay, so for this is the information leaflet about clozapine tablet and the Clozaril brand name. This medication is considered like old medication, approved since 1989. It's not a new medication, approved by the FDA. You can see the black box warning here. The black box warning, the first one, before you give any information, there's a warning about clozapine. And this medication may cause severe neutropenia, orthostatic hypotension, bradycardia, syncope, seizure, myocarditis, cardiomyopathy, increased mortality in elderly patients with dementia-related psychosis. So you can see it here that we only address the first part of warning with you. Okay, moving to the discussion of adverse drug reaction related to the atypical antipsychotic. Okay, moving to the second group of adverse drug reaction, but this time related to the atypical antipsychotic. Here when we say atypical antipsychotic, we mean here the second generation antipsychotic, atypical antipsychotic. What we have here, this group of medication, the advantage, This group of the medication do not increase level of prolactin as a group. The group of medication, second generation or atypical, maybe have lower extrapyramidal side effect. But is there any side effect coming from the atypical and antipsychotic? The side effect coming from atypical, the second generation, for atypical second generation, it's like related to the something called metabolic syndrome. The patient may suffer from weight gain, may suffer from hyperglycemia, hyperlipidemia, and other side effects. So I will repeat it. Second generation, atypical antipsychotic side effect, the major side effect, weight gain, risk of diabetes, hyperglycemia, and hyperlipidemia. Okay, this slide here give you some data, some statistic about the adverse drug reaction, and we discussed the endocrine side effect regarding the antipsychotic medication. So someone may ask, okay, prolactin, increased level of prolactin and cause hyperprolactinemia happened with which type of antipsychotic medication? Someone may answer that. Third generation antipsychotic inhibit dopamine D2 receptor, increased level of prolactin, and they found, according to the study, about around 70% of patients are from hyperprolactinemia. So we have case study here. The patient came to the clinic, suffer from schizophrenia. As a prescriber, you prescribe the first generation antipsychotics such as haloperidol to the patient, and the patient after 1 month, 2 months come to the clinic, suffer from galactorrhea, discharge milk from the breast, and this one related to the increased level of prolactin in the pituitary gland. The second generation of antipsychotic, especially clozapine, olanzapine, associated with a high level of weight gain. So the patient start gaining weight without any explanation. Next we move to the new onset of diabetes. 60% of patients on clozapine, olanzapine, quetiapine, risperidone. 60% significant number of patients may start suffering from diabetes, and this happened during the first 6 months of the treatment. So we have here three main cases related to the endocrine effect. Number one, third generation cause hyperprolactinemia. Clozapine, olanzapine, weight gain. Clozapine, olanzapine, quetiapine, risperidone cause the new onset of diabetes. What about adverse effect of on the cardiovascular system? Orthostatic hypotension with the third generation. Orthostatic hypotension, here we talk about third generation antipsychotic. Clozapine, quetiapine had the highest incidence of orthostatic hypotension. QT interval torsade de Bouin, QT prolongation happened with the haloperidol and the zibrasidone, cardiomyopathy, myocarditis, clozapine, lipid changes, elevated level of triglyceride and cholesterol happened with the clozapine, occur with the clozapine, quetiapine, and olanzapine. All these may be linked here. I will click on one of these links to review it together. Okay, this one belongs to the haloperidol, and one of the most important medication for the haloperidol. Okay, make it a little bit big or large indication for haloperidol. You can see here this medication, haloperidol, indicated in the treatment of schizophrenia, and this medication could be indicated for the Tourette syndrome also, Tourette disorders. Continue speaking about adverse drug reaction. The antipsychotic medication may cause anticholinergic effect, and especially happened with the first and the second generation of antipsychotic, but mainly we see this effect with the third generation. Some second generation, such as clozapine, olanzapine, may cause this one. This one very popular in older adult patients compared with the young. So with the anticholinergic, okay, it's happened with the low potency first generation, older adult patient, and with the olanzapine, clozapine. What the patient here suffer from anticholinergic effect. Here, remember, we are talking about atropine-like effect. Okay, that means the patient may suffer from dry mouth, the patients are from dry mouth. Okay, the patients are from dry mouth, constipation, tachycardia, all these atropine-like effect, blurred vision, impairment of ejaculation, urinary retention, and impaired memory. So when we finish our lecture about antipsychotic, we expect the audience, the student, maybe the individual who attending this lecture to answer this question: what is the most potent typical first generation antipsychotic drugs? Which of the following is not a typical antipsychotic drugs? Which of the following is not atypical antipsychotic drugs? Which of the following is or are neurotransmitter most involved in the schizophrenia? We have acetylcholine, epinephrine, serotonin, dopamine, glutamate. Which of the following the most important dopamine receptor involved in schizophrenia? We have dopamine 1 to 5. Which of the following is the most important serotonin receptor involved in schizophrenia? Which of the following is the mechanism of action of typical first generation drugs? Or which of the following is the mechanism of action? Which of the following represent the mechanism of action of a typical second generation? Which of the following drug of choice for patients suffering from resistance schizophrenia? Okay, this will conclude our lecture about schizophrenia and antipsychotic drugs, and we discussed mainly two main groups used for schizophrenia: first generation FGAs and the second generation typical antipsychotic, and we focus on a lot of mechanism of action, the clinical use, side effect, and maybe the recommendation for use, and for example for patients from Tourette syndrome, schizophrenia, nausea and vomiting. At the end of this lecture, thank you so much for watching, and see you again for another lecture in the central nervous system clinical pharmacology, and have a great day everyone.